Good afternoon, everyone, and thank you for joining us today for our webinar on transitioning from FIG to FO. We have a great presentation for you today, and it's great to see so many new names pop up on the attendees list, so thank you very much for joining us. The webinar will be recorded, so if you do have to leave early or one of your colleagues wasn't able to make it, we will have a recorded copy of it within a couple days, so please feel free to email me after the presentation, and I'm happy to get you on the list to get the recording and obviously answer any questions that may come up during the presentation. So with that, let's go ahead and get started. So just a little bit about Cirrus, and we do have a few new members today. We were founded back in 1994, headquartered in Toronto. We have two major components to our business. One is office lease negotiations for all medical practitioners across North America. And we also have our healthcare consulting team, which I am part of. And we provide billing support, operational consulting, and overall management for family practices within Ontario. So a couple quick facts as we get started. Physicians, contrary to popular belief, are better compensated in Ontario than anywhere else in Canada. Yes, of course, there are some cuts coming, who knows what's going to happen, but you guys are still, especially in the FO model at least, very well compensated, and it is the best in Canada. More than 75% of physicians say their pay does not align with the care they deliver. Now, what does that mean? It means that physicians are providing the care, and we all know that, but they're not necessarily being paid appropriately for that because they're not necessarily billing the right counseling code or the right diabetic code or whatever the case may be, because they don't have the time to think about what code should they be billing. So that's where we come in, and we help distinguish, what are you billing and what could you be billing. The majority of the province is practicing in the FO model. And physicians, as I said earlier, they're not strategic, so that they're not thinking about how they're being paid, what they're doing, because it can be confusing. And, especially with the schedule of benefits being so big and so confusing, and the wording and in the Ministry of Health, it gets very confusing. So allow us to help you with that and really dig deep within your practice to see what's going on, what are you billing, what are you doing, and make sure that you are getting paid for what you're doing. So the purpose of today's program is to increase your understanding of the FO model, compare of the FIG and FO model, and leave you with a much clearer picture of what the FO was all about. And, obviously, they may open it up again, FO spots to some people, or maybe to everyone, but who knows. But it is still a good opportunity to learn about it because there's still opportunity to join a FO, whether it's in a high needs area or whether or not there's a vacant spot in a FO that you're able to join, or maybe you're going to take over for a physician that's leaving. Maybe they're retiring or moving or whatever the case may be, and you're going to be taking over their practice. So you still need to know what's going on and what are the important factors. So what is a family health organization? So it's a payment model whereby the physicians are paid monthly for having patients on their roster. You are the most responsible physician for those patients, and you're going to get paid a monthly fee to have those patients rostered to you, as opposed to the fee-for-service world where you're only paid when you see that patient. In the FO world, you're getting paid regardless of whether you see that patient. So rather than being compensated based on volume, you're now focusing on medically necessary visits. So you're not bringing everybody in for every script renewal or every cough or cold or every follow-up. You want to bring those that are medically necessary, those that really need your time to come into the office and actually see you and actually be treated. Those that don't have to come in, those that are not medically necessary, we can have the nurse or the staff or someone respond to them with follow-up or booking another meeting or whatever the case may be, and not waste your precious time by having them come in for something they don't need to come in for. Bottom line, throughput versus access. In the fee-for-service or even FIG or CCM world, you want to see as many people as you can. You want to be a revolving door to get paid as much as you can, whereas in the FO world, it's all about access, providing access to those patients that are medically necessary. So a little comparison now on the FIG and FO model. So within the FIG, you have your comprehensive care as your fixed payment, so roughly $30 to $50 on average. Whereas in the FHO world, you have your comprehensive care plus your base rate payment, which can be about $160 a year per patient. So in the FHO world, you're looking at give or take $200 a patient per year, whereas in the FIG world, you're only looking about, let's call it $40, $50 per year. Performance-based incentives. So now, everything is pretty much the same in the FHO as coming from the FIG model. However, within the special premiums category, there are 3 new ones. And you also have access to your access bonus, which is related to outside use, and shadow billing, which is every time you see one of your rostered patients. And we'll get into a little bit more detail of all of these categories as we go through the presentation. So in the FIG and FHO income breakdown perspective here, you can see on the left, fixed income in the FIG, very small, fixed income in the FHO, very large. It gives you predictability, it gives you stability, it gives you the opportunity to potentially seek out other types of medicine that you're interested in participating in. It just gives you the flexibility to not have to worry every day, every week, every month about how many patients are coming through the door. So when moving to the FHO, we see about an 18% increase in income. And in some cases, it can be a lot higher than that. So it really is a great opportunity if you're practicing the right way to be in the FHO model. So a little bit more about FHO education now. 6 major income streams within the FHO, as you can see listed on the left there. The fixed income, so your capitation, is by far and away the largest portion of FHO income. And again, that gives you the predictability month over month of how much am I going to earn. Whereas in the FIG model, it's the complete opposite. You're only having about, let's say, 20-25% of fixed income and 75-80% of variable income, which again is a lot of volatility, a lot of potential to lose income if you're not working the same amount every month. So it's really very hard to plan. So capitation payments in the FHO. So again, it's a monthly payment provided for rostered patients based on the age and sex. It covers 126 fee codes that are considered in basket. So that's your A7s and your standard care that you're providing to these patients on a regular basis that they considered in basket, that they're essentially prepaying you to provide care. So they know you're going to see these patients or potentially going to see these patients, so they're prepaying you for those visits, but every time you see them, you still get your shadow billing. Every other code, so anything other than the 126, is considered out of basket, and you get paid the full value of that code the same way you would get paid in the fee-for-service world. Again, FIG physicians should be taking advantage of the guaranteed income of your comprehensive care. So again, excuse me, as we spoke about, the fixed portion in the FIG world is your rostered patients that you get $35, $40 a patient. Again, if you're rostering those patients, that's fixed income of, for every 500 patients, about $17,500. So it is a decent amount of money that you could be guaranteed. So a little breakdown here in chart form of how payments go according to age, sex breakdown in the FHO model. As you can see on the far left, just as they're born, just under $200 a year. They drop down. Females go back up again at age 14. Males don't really go back up again until their early 30s. But after that, there's a steep incline there, and you get quite a bit per patient that you have rostered to you. So it really is, again, if you're practicing the right way, having the right number of rostered patients will give you fixed income, guaranteed income, predictability, flexibility, everything that a FHO physician is looking for. That every physician is looking for, I should say. So what does fixed income give you? As I was saying, predictability, flexibility. You don't have those peaks and valleys anymore of how many patients am I seeing? Am I seeing enough patients? If I want to go away for a couple weeks, what's going to happen to my income? Also, this is a little bit less relevant right now because most people are on EMR already, but if you're taking over a practice that doesn't have EMR, you don't have to worry as much because yes, you're going to be seeing fewer patients because you're dealing with the transition, but you're still getting paid for those patients you have rostered, which gives you that, again, flexibility. We highly recommend looking at your rosters on a regular basis. You know, a well-managed roster throughout the transition period is really your biggest generator of income, and we really recommend looking at that very closely. Oftentimes we find when physicians come to us, you know, for our ongoing management services, they don't know how many patients they have rostered. They don't know the breakdown of males, females, and ages. It's such a large component of your income that it really is important to take a close look at that. As you can see, 2,400 patients, $480,000 of fixed income. That's not including the 20 to 30%, depending on your practice style, of variable income that you could earn on top of that. So it really is a very, very large component of your practice and something that is extremely important. So effective roster management, balancing a roster size versus access for patients. So as I said earlier, in the FHO model, it's all about access, allowing patients the ability to come see you when they need to come see you. So if you have 3,000 patients, some physicians aren't going to be able to manage that properly, and they're not going to have access for their patients. They're still going to book them out 2, 3, 4 weeks, maybe even longer. And that's not in this FHO spirit. We want you to have a manageable roster size where you can have open spots during the day, see the patients that are medically necessary when they need to be seen. If they call in the morning and say that there's an emergency that doesn't require an emergency department visit, but rather coming to you, you have to make sure that you have the availability to see them. And that all stems from the FHO spirit of having a balance between the roster size and access for patient. And the whole thing about roster management is a roster reconciliation and looking at your rosters as they compare to your ministry roster and your EMR roster. Again, many times we find that when physicians come to us, they have no clue who's rostered to them or who's not rostered to them or anything like that. So it really is very important to make sure that there's an alignment between your MOH and EMR roster. Again, capitation is the greatest generator of income in the FHO model. Now let's talk a little bit about fee-for-service. So most of you who are in fee-for-service or FIG or CCM, that's the world you come from, so that'll resonate more with you. So now we have to look at, when we're in the FHO model, we have two buckets of patients. We have enrolled patients and we have non-enrolled patients. Within the enrolled patients, on the left there, you have out-of-basket fee codes, which you get paid 100%. When you see them for the in-basket, as I said earlier, you get paid your shadow billing, which is 15%. When you're seeing non-enrolled patients, you have 100% value for any code that you see them for. However, there is a hard cap that is subjected to the group, so it is group-wide, that doesn't allow you to have an unlimited amount of in-basket services to non-enrolled patients. And the reason that is because the ministry wants patients to be rostered and not de-rostered. However, within the first year of joining a FHO or creating a FHO, you do have the ability to bill as much as you want in order to, again, see as many patients as you can to get them rostered, because, you know, the first visit, maybe 2 visits, they're not necessarily going to be rostered right away because you're checking them out to see if you want to be their physician. They're checking you out to be if they want you to be their physician. So you want to make sure that you don't have those restrictions. And in the first year of the FHO, the ministry has lifted those restrictions. After that, it's about $55,000 to $60,000 per year per physician combined at the group level. So let's take 60,000, 10 physicians, 600,000. Everyone in the group is allowed to bill up to that amount. Some might bill more, some might bill less, so it'll all even out in the end, hopefully. But if you do go over, the ministry does claw that amount of money back. So one of the main components of fee-for-service billings in the FHO that we like to focus on is diabetic management. And this is one that is highly valuable, and a lot of physicians don't necessarily pay close enough attention to this. If you have an average roster size of about 1,500 and you have 120 to 140 diabetic patients, and some of you will have a lot more than that, that's $26,000 to $30,000 additional revenue that you're going to be adding to your bottom line based on all your diabetic codes. And if you look at a diabetic patient as a whole, as fee-for-service, and you're in the FHO, so your capitated model, that's $52,000 to $60,000 just from those 120 to 140 patients that you're seeing as diabetic patients. So it is a very lucrative way of caring for your patients. And again, most of you have a significant amount of diabetics, so it's just very important to make sure that you're billing them appropriately. Net access bonus. So now this might be a new concept to some of you, as it really is only in the FHO model. What it essentially is providing access to your patients. Now, you want to make sure, as I keep saying, you have open spots for your patients that they can come see you in a timely manner when it's medically necessary. If your patients start to go to the walk-in clinic, this is where the access bonus comes in. You start losing from your access bonus. Now, every physician, based on roster size, has a potential bonus amount every year. So it's broken up into two 6-month categories, and every year the ministry will set aside a bonus potential for you. Every time one of your patients goes to a walk-in clinic, that amount, whatever is billed, whether it's an A7 or a K5 or a K013, whatever it is, or anything that's very specific, like sorry, I lost train of thought there. Anything specific like drugs or anything like that, it comes off your access bonus, and it's reduced dollar for dollar. So example, A7, $33.70, that comes off your access bonus potential each and every time one of your patients goes to the walk-in clinic. If at the end of the month you're in a negative position, that amount carries forward for the next month, and so on and so forth for the 6-month period. After the 6-month period, if a physician is in a negative position, they don't receive their access bonus. If, however, they are in a positive position after the 6-month period, the ministry will deposit those funds to the group account, and the physician will be eligible to receive their access bonus. At this point in time, there is no negative payback, and a lot of physicians are talking about negative payback, and when is it going to happen? It hasn't happened yet. It hasn't really been discussed yet. It might happen at some point in time, whereby if you finish a 6-month period in the negative, the ministry will ask for that money back. We don't know when it's going to happen. We don't know if it's going to happen, but it is a potential. Those that are negative in the group as well impact those that are positive. So if you have 10 physicians in the group and half of them are positive by $5,000 and half of them are negative by $5,000, the group will receive nothing because the positive 5 and the negative 5 equal out to 0 and nobody gets anything. So it really is important to work as a group and work as a team within the FHO model to reduce outside use and increase access bonus. Some of the challenges, of course, are patient behavior. It's, at a certain point, it's very hard to control it, but you want to educate them as much as possible. Every visit, every room should have posters. The staff should be telling them each and every time they come in, especially at the beginning of a practice when you're starting out or taking over. You have to educate your patients on a very, very regular basis. Patients are unaware, so again, they don't understand it. You need to explain it to them. Not having open appointments during the day. All comes back to access. You need to have those appointments available for patients that have a medically necessary visit. Patients are unaware of the after-hours care, so in the FHO model, you have to provide after-hours in the evenings from 5 to 8. The number of shifts are dependent on the group size, but you have to at least a couple during the week from 5 to 8 p.m., and then depending on group size again, you might have to do a weekend. So letting them know that it's available to them and they don't have to go to the walk-in clinic. And who are you referring to? Those physicians that have focused practice designations for addiction or sports medicine or diet clinics or whatever it is, make sure that they have that focused practice designation before you submit a referral to them. If they don't have it, try and submit to somebody else, or give them a friendly reminder that they can apply for a focused practice designation, and they'll get more referrals from you and others. So a little bit about how we help manage outside use. So we use a proprietary software that involves the process of collecting outside use reports from the ministry, and we do that via MCEDT. and we analyze the data. We look at the patterns and trends that are occurring with your patients to provide you with analysis, a cost-benefit analysis of when it makes sense to de-roster a patient, because in some cases it does. And it really is a little bit of give and take between when to have them rostered, when to de-roster them, when to potentially re-roster them, for example, if they're a university student or if they're going to the diet clinic for a short period of time or they have a sports injury. Whatever the case is, you have to monitor and you have to pay close attention to who those patients are so you know when to de-roster and when to potentially re-roster. So 2 snippets from our report. We look at the codes that are being utilized, and we look at the days of the week that are being utilized outside of the clinic as well, because it gives you a better picture of what your patient's needs and requirements are. If all of a sudden, one of the days that you're not there, you see a really big spike in outside use, perhaps putting in a couple hours or changing your schedule before and after that day, allowing for more open spots, especially the day after, because if your patients know, for example, that you're not there on Wednesday and they say, you know what, let me try and hold off, I don't need to go to the doctor right away, they try and hold off until Thursday, they can't, they try and call your office, they can't get a spot, they go to the walk-in clinic. But knowing that Wednesday is potentially a day for people to go out or your day off, leave more open spots on Thursday so you have that ability to see those patients when they do call in or walk in. So as I was saying, the cost-benefit analysis. So we look at who the patients are, when are they coming, what are they billing outside of the clinic. So we're looking at how much they're getting, how much you're getting in capitation versus how much they're billing outside of the clinic. And we look at that cost-benefit analysis. Once they reach 100%, they are no longer valuable on the roster, and we want to de-roster them. So again, we're also looking at number of services being billed outside the clinic. We're looking at the number of months it's occurring over that period of time. When was the earliest? When was the most recent? And what services were being utilized as well. It's very important to look at the services that are being utilized, because if there's a lot of A3s or K131s or physicals and addiction and things like that, sports medicine, those are high dollar value codes that we want to try and get rid of from the outside use report. So we want to get rid of those patients or have a talk with them and figure out what's going on if you're not already aware. Preventive care bonuses. So in the FHO model, 12,800 available across the 5 categories. Everyone should be fairly familiar with this. Nothing really changes in the FHO model. Special premiums. So now, special premiums, 37,000 available across these 8 categories, sorry. 5 categories move over from the FIG, so we added 3 categories there, hospital, office procedures, and prenatal. For most physicians that we work with, prenatal, if they have females in their practice of childbearing age, very easy to get. You only need 5 patients, and you only need at least 1 visit of a prenatal code, so that's a P003 or 4, and then you can ship them off to the OBs. Office procedures, if that's something you do, very easy to obtain. You need $1,200 worth of services over the year to get that $2,000 bonus. If it's not something you do, then potentially something that you could look into and just add another revenue source to your income. And hospital is very particular to the physician. We don't see a lot of physicians providing hospital work, but there are quite a few. So if it is something you do, why not take advantage of that bonus? How can Cirrus help? Not only the practice, but the FHO as a whole. So not only the individual physician, but the group. All FHO physicians and all physicians in general are looking for the balance of income, flexibility, and work-life balance. You need to have control over your practice. The days of working 7 days a week, 12 hours a day, people don't want to do that anymore. And physicians, in some cases, are required to do that straight out of medical school because they have so much debt, potentially, and because they have family obligations, and they need to pay it off as quickly as possible. But moving into the FHO model, so whether you're, as I said at the beginning, whether you're taking over from a retiring physician and buying their practice, or there's a vacant spot and that you want to join that FHO, or you're in a high-needs area, or they do eventually open it up again and you start your own FHO in an area that is comfortable for you, that you know you're going to be able to get patients. Everybody's looking for the balance, and that's what the FHO provides. So we help with education. We help with both the physicians and the staff. We educate them on what it means to be part of the FHO. We help on how to educate your patients as well. And we teach you the inner workings of the FHO. What does it mean to be part of a FHO, both from a staff and physician standpoint? We look at a governance agreement. So if you're joining a group, what are your obligations? If you're creating a group, what do you want your group obligations to be to each other and to your patients? If required, we can help with group accounting, so we can help with the banking. We can help with the distribution of funds that are going to be coming into the accounts, into your group account. Income optimization. We help make sure that you're getting paid for the care that you're delivering. That's the bottom line. We want to make sure that if you're providing the care, that you're billing the right code and getting paid the right amount. We have a Cirrus Helps hotline. We have a great team here at Cirrus that is always available to answer questions, whether it's your personal consultant or one of the support staff or anyone else here. We're always here to help. We're always here to answer any questions that you have that will make your life that much easier. We help by utilizing all your data. So again, we collect from your MCEDT account. We take a look at all your reports on a monthly basis. We download everything. We provide that back to you if you would like. We have something called ShareFile, which is an online portal that we can share and send the reports in a secured way. We look at your error reports. We look at outside use reports. We look at RA summaries. We look at your bonuses. We do roster reconciliations. We literally look at every component of your practice as it relates to your income to make sure that you are doing what you need to do. And it's tackled step by step. You can't do everything at once. It has to go step by step. Roster reconciliations, very important, top of the list. Fee-for-service revenue increases. We have a billing and data analysis report that will show you what you're doing, and we will discuss together what you can then switch to or change or manipulate or whatever you need to do in order to get paid for what you're doing. Outside use management, extremely important in the FHO model. And just overall looking at all the bonuses and premiums and tracking codes that you need to do in order to get paid for the care that you're delivering. That's, again, the most important aspect for us is getting paid for what you're actually doing. So some of the key takeaways for today. In the FIG model, you want to review your bonuses that you're eligible for, those 5 categories, and make sure that you're doing the right ones. You want to ensure that you're rostering your patients. Again, even if you're in the FHO, in the FIG, and you're only getting about $35, $40 a patient, it's still guaranteed income. And when you switch to the FHO, it just makes it that much easier and smoother. Set up your preventive care bonus programs. Again, making sure that you're billing all the tracking codes and billing codes when the services are happening. In the FHO model, if you want to consider, you want to look at your income predictability. You want to look at the flexibility. You want to look at the rewards for offering complex care to your patient. We can provide you with an analysis to show you what your income will look like, what your life will look like, potentially, when moving to the FHO model. Be aware of outside use, daytime access issue, not on the weekends. On the weekends, you can bill the 888, and hopefully the walk-in clinics are doing that so you don't get dinged. But outside use is a very, very big component of being in the FHO, and it's something extremely important and something that you need to look at and something that we will help you manage. And you have the ability to de-roster retroactively. So if you, again, use our reports to analyze the data, look at the cost-benefit analysis, and then retroactively de-roster, you get back the outside use that was incurred in the previous 6 months. So just an added level of income to your bottom line. So that brings us to the end of the presentation for today. Thank you so much for joining me. If you do have any questions, my email and phone number are there. I would be happy to assist you or anyone else here if I'm not available at that time. Again, moving from FIG to FHO is a big decision, but it could be a lucrative one, and you really have to dig deep and figure out what you want to do, when you want to do it, and we're here to help you with that whole planning process, figuring out if it makes sense based on your practice style or your practice desires to move to the FHO. We have income analyses. We have a lot of different reports that will help show you whether or not it makes sense or what life will look like in the FHO. And we're happy to set up any meetings for those groups that are a little bit more ahead and want to create a FHO or join a FHO. we're happy to assist in any way we can. So again, thank you so much for joining me today, and I hope you have a wonderful afternoon.
Participant has left the conference.
Josh.